Good morning, everyone. This is Dr. Mo. Just so you know, I would like to thank you all for joining us today virtually for this awesome conference. I would also like to thank the organizers for giving me the opportunity to talk about something that is really close to my heart, something I love doing and talking about, which is periodontal plastic surgery, gum grafting. Given we only have a limited time, let's just dive into today's topic. Before we start, I would like to ask you all a very simple question. What if you saw this in your private practice? Or how would you manage a case like this? Let's say you see a case like this in your private practice, how would you manage it? What you're looking at is the area which is known as section 5. The focus is from 4.3 to 3.3. If you look at this image, you can see severe gingival recession at 4.1. Loss of buccal bone, thin tissue, frenum pull, shallow vestibule, mucogingival defect, lack of keratinized tissue, lack of attached gingiva. How would you manage this case? Before we answer this question, let me take a step back and briefly describe my intro so that you can get a better understanding where I'm coming from. I was born, brought up, and raised in Lahore, Pakistan. Did my basic dentistry at FMH College of Medicine and Dentistry. Once I had done my BDS, I came to Canada and I did my first master's at McGill University. I came to Canada in 2011, did my master's. After completion of the master's, I went to Vancouver, British Columbia, where I did my second master's. This was in master's in craniofacial sciences. Once I did my second master's, and I also completed simultaneously my periodontics residency, which is technically known as the diploma in periodontics and implant dentistry. Once I did my second master's and my periodontics residency, I subsequently qualified for the primary fellowship for the fellowship of the Royal College of Dentists of Canada. I also did my diplomat status with the American Board, which is known as Diplomat of the American Board of Periodontology and Implant Surgery. After completion of my educational career, if you will, I started full-time in private practice. I'm also associated with the University of Alberta, where I'm the clinical assistant professor, graduate periodontics. Recently, I am involved with the University of British Columbia, where I teach the graduate prosthodontics resident. Otherwise, my forte, if you will, is full-time private practice limited to surgical side of implant dentistry and periodontics. Recently, alhamdulillah, I was also selected as a board examiner for the fellowship of the Royal College of Dentists of Canada in the field of periodontics. And alhamdulillah, I'm the first Pakistani dentist who did his perio training in Canada, ended up doing both the fellowship of the Royal College of Dentists of Canada and is also a diplomat of the American Board of Periodontology and Implant Surgery. What you're looking at is a list of commonly performed periodontal procedures. This is what we routinely do in our daily lives as periodontists in North America. The procedures which are highlighted in red is what is defined as periodontal plastic surgery, known as the free gingival graft or the connective tissue graft. Now, with this background, let's get back to our dilemma. How are we going to fix these situations? What can we do? So in order to do this, in order to deal with it, let's first define what is gum recession or gingival recession. Simply put, it's the apical migration of the gingival margin, which results in root exposure. When we have this, it typically manifests itself like this. So if you look at this image, let me describe it. We can see there is some recession going at 1.3, extending all the way to the premolars and then the molars. In case you were wondering, these 4 dots are from the local anesthetic. So the local anesthetic is already being given in the form of infiltration. What I want you to look is the lack of vestibule. So meaning there's not much good attached tissue under the tooth, be it 1.3, 1.4, 1.5, or 1.6. If you really watch closely, you can see slightly some Stillman's cleft on the mesial aspect of 1.6 as well. So this is gum recession. This is what we have. Then what is gum grafting or soft tissue grafting or periodontal surgery? Well, it's the management of recession, be it the connective tissue graft or the free gingival graft. The procedures undertaken to manage the recession, simply put, is known as periodontal surgery, be it the free gingival or the connective tissue graft, which means the procedures which enable us to go from this situation to boom, this situation. So what you're looking at is a post-op taken at about 3-week time. You can see we've got complete root coverage at 1, 3, 1, 4, 1, 5, 1, 6. Interestingly, look at the vestibule. Let me show you here. Look at the vestibule now. The gain in attached gingiva, the gingival thickness. And we've got this amazing result despite the fact that there is plaque and calculus. This, ladies and gentlemen, is periodontal surgery. Now that we've defined the periodontal surgery, we've defined recession, let's look at some of the causes and associated factors. What causes it? So it's the plaque and calculus, history of aggressive brushing, frenum polars there. If you don't have the attached gingiva, it's associated with recession as well. Then the position of the tooth also plays a role. So for example, if you look at this image, this is a challenging case. It's a tough case. Look at the width of recession, the prominence of the root on bilaterally on both sides, the canines, the shallowness of the vestibule, the thinness of the tissue. If you look at this case, you can see that the roots are visible through the tissue. So if you don't do it right, there is a very good chance that could turn out, it could go south really fast. The other factors are tongue ring associated with the lingual recession, thin tissues, just like case like this, and the periodontal disease. So these are some of the causes. Now that we've talked about the causes, what about the consequences? Turns out it leads to compromised aesthetics. Plaque and calculus retention tends to be more. Sensitivity can be an issue. And then you can have root caries associated with non-carious cervical lesions. But importantly, which even the dentist miss, this thing means when you see recession, think about it this way. Gums, they're supposed to cover the bone, and the bone is what is supposed to cover the root or the roots of the teeth. But when you have recession, you don't see the bone. Why? Because the bone is already gone, which means in a case like this, for example, we have lost the buccal bone, at least to an extent, which also means that the periodontal support of the tooth is compromised. A question that a lot of my patients ask me, they say, Mo, will the recession progress? Will it continue? To answer that question, let's look at the literature. So the literature tells us that when you have about 3 millimeters of recession, the chances that it's going to progress are about 70%. But if you have 4 millimeters of recession, it's almost inevitable that it will progress. But look at one thing. The difference between a 3 and a 4, not much, only 1 millimeter, but the likelihood that it's going to progress further and further from a 70 to almost 100%, 30 times increase. So that basically means that when you have a certain threshold of recession, let's say around 3 millimeters, it's very, very, very likely that it's going to get worse. Number two, at a certain threshold, even 3 millimeters in a lot of cases becomes challenging to manage. So probably it's wise, it's prudent to get hold of the patient, discuss the case, and try to manage on early. So in this particular case, you can see there was recession associated with tooth number 2-6. The mesial root is a little bit exposed. Patient did not get any treatment. And lo and behold, just a few months in, and we see this. We can see the recession has progressed. Now it's going to the mucogingival junction, and it becomes more challenging. The root is a little prominent. It's a molar posterior. It's not an easy case, and it will only get difficult. Fortunately, in this case, at this stage, we were able to intervene and we got complete root coverage. Now, the question is, what are some of the goals that we want to achieve with gum grafting? So what we want to get is a zone of attached gingiva. We want to get thick tissues. We want to eliminate the frenum. We want to increase the vestibular depth. But perhaps, most importantly, from a patient's perspective, this is what they are looking for, root coverage. So what they want is for us to be able to go from this situation with severe recession to boom, this situation. Almost complete root coverage. Look at the keratinized tissue, the attached gingiva. This is what will protect the tooth in the long term. This will compensate for the missing buccal bone perfectly. This is what you want. So now that we've talked about the root coverage, the question is there a way that we can predict what is a realistic expectation of the root coverage? And in order to set the expectations straight, we periodontists typically world over, we use this classification known as the Miller classification. Now, to make it very simple and easy to understand, I will simply say, when you have a case which is class 3, which basically means loss of interdental tissue. When you have a case when you've reached a stage where the interdental tissue starts to go away, then getting appreciable root coverage becomes more and more challenging and unlikely. The more interdental tissue you lose, the more unlikely appreciable root coverage is. Class 1 and 2, they are generally speaking, relatively speaking, in a lot of cases easier. The wrong way of saying it is that we can get 100% root coverage. That is perhaps not the right way, because if you look at the AAP, American Academy of Perio paper as well, they published the report in 2005 or 6, and they said even in class 1 and class 2 cases, typically the root coverage, the mean root coverage was around 85% when using connective tissue graft. So the bottom line is class 1 and class 2, where we don't have the interdental tissue loss or bone loss, there is a good chance that you may get really good root coverage ranging anywhere between 85 to 100%. But when you have interdental bone loss or tissue loss, the chances that you're going to get good appreciable root coverage, they start to go down south. And with class 4, unlikely. Now, with that in mind, let's look at the techniques. Let's look at the 2 commonly performed procedures which constitute periodontal plastic surgery. The first one I'm going to show is the free gingival graft. What you're looking at is a case which was done by my colleague. So my colleague did a connective tissue graft, a gum grafting procedure in the lower anterior. Once he had done the procedure, he saw the patient for the post-op, and it did not go well. So it was a failure, unfortunately. My colleague gives me a call and says, Mo, I'm sending you a case, I'm sending you a picture right now, and I'm sending you this patient, deal with it, fix it. And of course, the patient was a little upset. This is the picture that I got. So what you're looking at is the post-op picture, 2 weeks, 3 weeks. So this is a good picture in the sense that when you see something like this, you've done a connective tissue graft and looking at this, it tells you that it's not healing well. It hasn't worked. It's a failure. Now you have to manage it. So when I saw the patient, I saw this. On the left-hand side of the screen, I can see the radiograph, commonly known as the X-ray. On the X-ray, or radiograph as you say it, we can see the interdental bone loss. We can see a little bit of plaque calculus in the area, but it's the interdental bone loss that you can see in the area. So instantly in my head, I'm thinking, okay, there is loss of interdental bone, so that is a Miller 3, meaning not very likely that I can get really good root coverage. So that means I need to set the expectations straight, give realistic expectation to the patient. Then I look at the area clinically. Clinically, once again, I can see the black triangle, clearly showing what we're looking at the radiograph, that there is interdental tissue loss. Then I see that there is recession associated with the incisors. The other thing is, think about it this way. The more teeth there are, the biggest surface area is there which doesn't have blood. So always think from a healing perspective. What do you need? You need blood for optimal healing. So that means it's a wider area. It's a bigger surface area which doesn't have blood. So that means it's going to be challenging. So I talked with the patient and I said, okay, the graft has failed. I would like to go with a free gingival graft rather than a connective tissue graft. I wouldn't go into details, but there are reasons. The vestibule is shallow, the tissue type is not good, the frenum pole is there, I want to increase the vestibular depth, I want to increase the tissue thickness. So all of those reasons, I wanted to do a free gingival graft, and fortunately, the patient allowed me to go with a free gingival graft. So what did we do? This is what we had. So on the day of surgery, all I did was I raised a partial thickness flap, and this is what you see. So in this case, we've raised a partial thickness flap. Once we have reached this stage, now I will go to the palate and I will harvest the free gingival graft. To make it very simple to understand, that simply means when I'm taking the tissue from the palate, I am taking the surface epithelium along with the graft. So it's in terms of wound healing, it will be an open wound healing, healing by secondary intention, just to make it simple. And that would be a difference, not all the difference, but that will be a difference if we were to compare the free gingival graft from the next one, which will be the connective tissue graft. So let's come back to the picture. So what you're looking at is a site where the partial thickness flap has been raised. Once I've raised the partial thickness flap, I go to the palate and I harvest my tissue. This is how it looks. So in this image, the graft has been harvested. Now, when this picture was taken, I was actually doing the surgery. I was trying to position my graft and see how it fits. And instantly I can see that it really nicely fills in the periosteal bed or the recipient site which is going to receive the graft. So it looks very nice. Once I've done that, I'm happy with my positioning, then it's time to suture the area. So this is what we had. This is what we did, which was partial thickness flap. And then we place the graft and now we're going to secure it. So you see a lot of suturing. So primarily, principally speaking, there are two types of sutures involved. One is simply put the interrupted type of sutures, which are on the side, for example, here, a couple here. The purpose of these sutures is to just hold the graft in place initially. Then you see a lot of these crisscross sutures. These are sling sutures, or also known as the periosteal sutures. What is the purpose? The purpose is that these sutures, they allow the graft to be really solidly bind or attached to the roots of the teeth. So what it does is it eliminates the dead space, eliminates the voids, and it would facilitate the soft tissue cells, be it the epithelial, be it the connective tissue cells, to form the attachment to the root surfaces. So once we've done that, we were able to go from this situation 3 weeks later, around 3 weeks later, post-op. And remember, this is a Miller class 3, interdental bone loss. We don't expect a lot of root coverage, and yet we were able to go from this situation to boom, this situation. We see almost complete root coverage, and we see the keratinized tissue. There is elimination of mucogingival defect. There is gain in keratinized attached gingiva. The frenum pole is taken care of. The vestibular depth has increased. The tissue thickness has increased. And this is just week 3. It just gets better with age. So this is an amazing, and interestingly, okay, there's plaque and calculus. Understandably, patient did not do any hygiene. Typically, I asked them just to use chlorhexidine mouthwash during the healing. But there is improvement in the papilla. That's amazing. So this is free gingival graft. Now let's look at the other technique, the connective tissue graft. So what you're looking at is a case where we have recession associated with tooth number 1, 3, a little bit on 1, 4 as well. The interesting thing is, in this image, all the incisions have already been given. All the things that you need to do at the recipient site, already done. So that's why, one of the reasons I really like this technique of connective tissue graft. It's technically called the tunneling technique. I absolutely love this technique. It takes a little bit more time, more challenging, more technique sensitive, if you will, but it's a beautiful technique. You cannot see any incisions or anything, and yet all the incisions have already been given, as you will see in the subsequent pictures. So once you've reached this stage, you go to the palate once again, but this time the difference will be you give a single incision, one single sleek incision. Through that incision, I can harvest my tissue. This time, we will keep the epithelium so that once we've taken the graft out of the area, we can close the area primarily. And all you will see at the end of the surgery, at the time of suturing, is a single line. So that means, in terms of healing, very minimal morbidity, very manageable, and very sleek procedure. This is how it looks. So if you see this image, this is my incision line. This is a single incision line. These are the sutures. They're dissolvable, they'll go away by themselves. These are the palatal rugae. So think about it this way. This area, the tissue has already been taken from this area, and yet it looks thick and it has primary closure. So that means very nice healing for the patient. So once we've taken the tissue, the question is, how does the tissue look? This is how the soft tissue graft looks. This is connective tissue graft. So once again, I've taken the tissue from the palate. We've already seen in the last picture that the palate has primary closure, looks really good. Now in this image, I am positioning my graft once again, just to make sure that I'm covering the teeth properly. Once I'm happy with this, next stage is to put this graft under the existing gums, if you will. And this is how it looks. Once again, looks really nice. So this is the amazing thing with this technique. We have somehow slipped the graft under the gums without raising the papilla or anything. So the blood supply is optimal. The risk of things going south with this technique are less because we have not opened the papilla. So this is a beautiful technique. The tissue is already inside the gums, and that is what we have. And then what we will do is we will give simple sutures, sling sutures. So given we have a little bit of time constraint, I will not go into details of different types of sutures or techniques or material, whatnot, but simply put, in this particular case, we gave sling sutures and we were able to go from this situation again, 3 weeks, just 3 weeks post-op. And boom, this is what you see. Complete root coverage. The tissues are really bulky and thick. We have got attached gingiva. We've got increase in the vestibular depth. And this thing is what supports the tooth now. So when you have missing buccal bone, what you need is a really nice band of connective tissue graft that will stay, will protect the tooth. But the question is, this is a very nice, very sleek procedure, but let's say you have a wider area, a bigger area, a more challenging area. How would you manage that? Something like this. Now look at this picture. That's amazing. I love what I do, and I try to go into details of things. So if I was to make it simple, the problem here is the extent. What you're looking at is recession is extending from tooth number 4-3 all the way to tooth number 3-5. So 3-5 is an area which doesn't have much recession, but 3-4 has recession. All across, we have a lot of recession. But the important thing is, look at the width, the height. That means when a tooth has a lot of recession, but it's narrow, then the surface area is less compared to this situation where it's quite wide and multiple teeth. So a lot of area which doesn't have blood supply. Again, always think from a healing perspective. So in a case like this, I knew that taking tissue from one side will not cut it. So I would have to go to both the palatal halves. So this is what we did. We went to the right and the left palatal half, single incision, took the tissue out. We were able to get about 55 to 60 millimeters of tissue. Next, what I did was I sutured them together to make one nice, simple band of connective tissue using resolvable tissue, the sutures, of course. And this is what we did next. Once we created that single band, so what you cannot really see here is that the connective tissue is going under the flap here, wrapping around tooth number 4-3, going to tooth number 4-4. So it's extending all the way from 4-4, coming out, going here, all across up until tooth number 3-5. So it's a very nice big band of connective tissue. Once we've done that, the tissue was already, the buccal flap was already partially raised. And this is the flap technique, Zucchelli technique, flap technique, whatever you want to call it. The buccal flap was released thoroughly, partial thickness. And now it's ready that I can coronally advance the buccal flap and close it off. So this is what we did. Next, we just simply advance the flap and we can see the sutures now being placed. Once it's done, let's have a look. This is what we had. Again, the post-op shows us, boom, almost complete root coverage extending all across. So this is what we typically do. This is beautiful, makes me happy. But the question is, I showed you this case and we ended up getting a really good result. We were able to go from there to boom, there. But the question is, what happened to the other cases that I showed in the start of my presentation? What about those cases? For instance, this case. So interestingly, for this particular case, we were able to get perfect result. We were able to get complete root coverage despite the fact that tooth is out of alveolar housing. Patient didn't want ortho and poor quality of tissue, completely out of alveolar housing, and yet we were able to get complete root coverage. And this case was recently accepted and already published in the International Journal as a case report. So this is what we got. Again, early healing, but shows you the idea that we were able to get the complete root coverage. This was the other case where we had, again, recession. And in this particular case, I saw the patient at 2 weeks post-op, and this is what we had. Once again, you can see the sutures are just removed the sutures, and my assistant took the picture, but you can see very nice coverage, very thick tissue extending all the way from the molar to the lateral incisors. So beautiful results. Similar thing, this was a difficult case. It's a challenging case. And in this case as well, we were able to get complete root coverage, thick tissue. Look at the roots. You can see them through the tissue at the canine level. So we did the gum grafting at the canine. The roots were prominent, and this is what we get. Beautiful result. Once again, look at the thickness of the tissue, complete root coverage, increase in vestibular depth, gain in keratinized tissue, gain in attached gingiva. This is what you're looking for. And what about the last case? What about the first case, which turns out to be the last as well? So this was the case. And once again, it's been over a year. The result has been stable. We were able to go from this situation to, boom, this situation. You see, complete root coverage, gain in keratinized tissue. The only thing is I wish patient took care of the oral hygiene much better, but another story for another day. But this is how it is. Now, before we call it a day, I would like to request you all that next time when you see recession, don't just think about aesthetics. Don't just think about sensitivity. Think different. Think about attachment loss. Think about buccal bone loss. Think about gum grafting. I look forward to seeing you all in person in future. Till then, stay safe and stay awesome. This is Dr. Mo signing out. Thank you.